We all know that 20% of Americans are driving 80% of the costs. We know that 5% of Americans are driving 50 to 60% of the costs. And what that's told us here at LBHN, and we anchor on it, is that we don't really have to boil the ocean to make a real impact in people's lives and their health outcomes. And it's inextricably linked, therefore, with costs. So if you can improve outcomes, you should darn it be improving costs. They go together. They're not opposite or mutually exclusive.
Welcome to A&M Healthcare Industry Group's What's Your Moonshot podcast series, where world-class healthcare leaders seek to solve big problems. Listen as we talk to today's health system CEOs about the journey to achieve their moonshots.
Good day, everybody. This is Martin McGahan. I'm a Managing Director and Head of Alvarez & Marsal's Healthcare Industry Group. Thank you very much for joining us on the What's Your Moonshot podcast, hosted by A&M. I am joined by my distinguished co-host and Senior Advisor, Dr. David Shulkin, the 9th Secretary of the U.S. Department of Veterans Affairs. David, welcome. Today, we have the honor and privilege of talking to Dr. Brian Nestor. Dr. Nestor is with Lehigh Valley as the President and CEO. He has been with Lehigh Valley since 1998, where he joined first as Chairman of the Emergency Department and then has been in the CEO role since 2014. Dr. Nestor is a past board member of the Hospital Association of Pennsylvania and current member of the AHA Health Systems Council. And Dr. Nestor, very excited and honored to have you on our podcast today. Welcome.
Thanks for having me.
And Dr. Shulkin, as always, welcome. Thank you for joining us, and I appreciate you joining us and being part of this, as always.
No, thanks, Martin, and I'm
super excited that Brian is willing to talk to us today on What's Your Moonshot.
Thanks.
Well, Dr. Nestor, as part of this series, we talked to leaders such as yourself who really have the opportunity to not only deliver and guide care throughout the country and in their local communities, but also as visionaries kind of rethinking what's possible in healthcare and think of this and thinking of it in the context of the moonshot of doing things in a broad visionary way and kind of driving how we think about care delivery going forward in this country. So I'll get started really just by asking you kind of your thoughts and for you to describe really what your moonshot is and how it encompasses what you do every day there at Lehigh Valley.
Yeah, sure. A couple points. I think first is recognition of some of the big problems that we have. We expect by 2030 we'll be spending roughly $3 trillion just on Medicare and Medicaid, depending on the totals that you're looking at. But in any case, that's a lot of money. We all know that. It's an incredible sum for the inadequate outcomes we are producing. And frankly, my bias is that $3 trillion should be enough to do a much better job. Is it enough to do everything? Probably not, possibly not. But darn it, there's plenty there for us to do a much better job than we're doing today. So that's number one. Number two, we all know that 20% of Americans are driving 80% of the costs. We know that 5% of Americans are driving 50 to 60% of the costs. And what that's told us here at LBHN, and we anchor on it, is that we don't really have to boil the ocean to make a real impact in people's lives and their health outcomes. And it's inextricably linked, therefore, with costs. So if you can improve outcomes, you should darn it be improving costs. They go together. They're not opposite or mutually exclusive. Sure, there's expenses we have to take out. That's our job as managers every year. Take the unnecessary expense out and the cost out. But in terms of managing the population, if you improve health outcomes, you will reduce costs because you're doing a better job of it. So we believe that. So we focus on the individuals in our community that are at the highest clinical risk because we believe that's the pathway or trail to highest financial risk. and therefore highest opportunity. So number three, don't have to boil the ocean. Number three is, and it's best yet, is that while any patient, any of us, high or low socioeconomic status, if you have commercial insurance, government pay insurance, or no insurance, you can step on a cancer bomb. Bad stuff happens to everybody indiscriminately, or you can have a catastrophic cardio or cerebral vascular event. Bad stuff happens. But if you look at the incidence rate of those, a preponderance of those individuals that are having those problems tend to be vulnerable in nature, vulnerable human beings. And if you're talking about vulnerable human beings, they tend to have a high density of Medicare and Medicaid beneficiaries or dual eligibles or those that are underinsured. So if you follow that logic, these are individuals that highly concentrate the 5% that are driving 50 to 60% of the cost. Again, back to number two, you don't have to boil the ocean. So if you can follow that logic and you believe in that logic, then who are those people? Let's find them. All right. And we know who they are. They're generally socially isolated, financially fragile seniors, or they are younger or older people that have the social determinants of health working against them. And these are people that have generally inadequate or non-equitable access to care because of the bad stuff that's in their life, the challenges in their life. So, as I kind of look at the things that drive the moonshot, as you called it. I've never called a moonshot until today, but I guess that is my moonshot. And it takes into account some basic figures, basic facts, and logic that for me reveals a really clear path for the future. And I'm a bleeding edge value-based care guy, and happen to be a hospital guy.
So, Brian,
how are you articulating the best way to identify those people? What needs to happen in your moonshot for you to be able to get to the right people?
It's really data. It's data analytics. You really have to put in place a system of care that allows you to do that. So again, if you believe in those three tenets, you believe in the logic, you believe that there's an association between high clinical risk, vulnerable humans, and high financial risk, that's the roadmap. Let's chase that. So we've been on the bleeding edge as a value-based company. We're believers in population health management, and we've built a company around it called Populytics. Population Health Analytics, a la Populytics Inc. And in the early days of conceiving this, that was around the ACA being signed in March of 2010. And to be honest, at the time, we didn't know what we were looking for. All we knew is, how the heck are we going to make any money in this new fee for value thing? And we started considering questions like, should we make the pivot to fee for value? Or even could we make the pivot for fee for value? And frankly, if we did, what the heck's the value proposition for higher quality care and lower cost? Remember, there's a lot of hair on the ACA, okay? At least our view. First of all, there's going to be no new money. Any increase will be minimal or modest. We are implementing new quality standards, and we're going to penalize you financially if you don't hit them. You're welcome to become an ACO partner. We welcome you in. And to do that, you have to hit your expense target and then save money beyond that. And if you hit a threshold of $10 million, we'll split that with you. Sounded like a very bad deal to us. And just in case you thought, you could still go to the payers and rob them, for the commercial folks, to pay for the subsidies you need on the Medicare and Medicaid side, we're going to regulate them with an 85% MLR. None of that sounded good to us. So frankly, we were struggling with fee for value. We didn't see it immediately as the place to go. But fortunately, after struggling probably till almost 2012, 2013, we found the new money. And the new money was in our 990. And it was in our community benefit, or AKA, also known patient direct care shortfall. And in 2014, that number was $440 million. What was of interest is that $300 million of those subsidies of those costs were subsidies paid because of insufficient payment from CMS for Medicare and Medicaid beneficiaries. So $300 of $440 million was this pile of money that, by the way, had been tripling every 3 years for the prior 12 years. Well, no, it becomes a duh, and I'm embarrassed we didn't know it. But, of course, that's the case when you have boomers booming and Medicaid expansion and Medicaid mandates. So, we finally had our head looking at that $300 million and said, that's our pool. That's our profit pool. If we can identify who those, go ahead.
Brian,
I'm embarrassed, but you lost me on the math. Okay. So here's what I got so far. It does not surprise me that you as a physician leader and Lehigh Valley as an organization have identified this area as vitally important to your mission, because, I've known you for a long time. I've known Lehigh Valley for a long time, and the Pool Trust was established to do exactly this, to look at population health issues. So this is in your DNA.
Yeah.
Now,
it doesn't surprise me that you're smart enough to have figured out that the traditional value-based payments
weren't going to get you there in a meaningful way, whether they're commercial payers or on the government side.
Yeah.
I've never heard anybody talk about the 990 and the community benefit funds before. So, but you have a big number there, and 300 and something million of it seems to me like it's a paper loss. So how are you actually tapping into that subsidy for Medicare and Medicaid to actually fuel your operations of your health system?
Yeah, it is a paper loss, but at the end of the day, our operating margin, okay, is less, okay, because we're not getting those dollars, okay. In addition, we are still taking care of those people, and it's displacing revenue from other patients who could be getting access, or caring for more Medicare beneficiaries and more Medicaid beneficiaries where we had reasonable payment in order to kind of improve our operating margin. So I'm oversimplifying a little bit with there's the bank, but the reality is we could move the company to work differently, okay, that could make us more profitable. Is it dollar for dollar? No, okay, but there's huge opportunity.
Well, Brian, that is a new map, and again, I think it's very,
very interesting because I've never heard anybody describe it that way. But you're saying
in the approach that you're using for population health, especially for
government programs like Medicare and Medicaid, you're not participating, taking the shared savings, and you're not looking for the savings out of the traditional ACO type programs. You're doing it the way you're doing it.
No, we are. No, we're using the math I just gave you on the 990 as the philosophical inspiration for why we need to do a better job at caring for vulnerable people who really wind up coming in at a late stage. Okay. Therefore, we throw the kitchen sink at them. We save them, but their outcome is less than optimal because we allowed them to be unengaged and non-engaged in their care. Therefore, at the end of that, if you take care of that same patient over a 10-year period of time, there's a present value loss, okay, of revenue related to poor care because it cost us more. And again, we are spending the money to take care of them in a non-optimal manner. So we distilled this down, by the way, to try and explain that. It's hard to explain that to our board and said, think of it this way. It's two concentric circles. On the inside is the gushy caramel center core of commercial insurance that we're going to, on fee for value, it's going to be there. We're going to do the best we can there. It is what it is. But more important are the government pay patients, Medicare and Medicaid. We're going to strive to lose less, okay, by providing better care. All right. Now, I would tell you our fiscal year 22, 990 direct patient gross shortfall is $759 million. Okay. 560 million of that, okay, is insufficient payment for Medicare and Medicaid. So this is a growing problem for us, even though we are entirely focused on it. And to answer your question, yes, we're targeting these people, and I can go into the analytics using clinical and claims data to identify them. I can tell you what streets they live on, where their greatest density is, and what community, by what zip code, by what census tract from federal government information, what their social determinants are related to local sharing of data sets, and what we do, therefore, proactively to prevent them from ever coming in the hospital. Or allowing them to go on hemodialysis at age 84 for 2 years as opposed to 65, okay, for 20 years. So sometimes just delaying a disease by giving them better control is also a victory as well financially. And by the way, on the commercial side, we have revamped all of our strategies and because that's where we have the best data. Federal government's not giving us a lot of data. For the first time, we actually have through Highmark acquisition of Gateway, we now have 65,000 managed Medicaid lives. Finally, we've got Medicaid lives. CMS fee-for-service ACO, we've got 45,000. Who cares? We see multiples of that, and we have to participate in the game, if you will, just to be able to get access to claims that are aged and old. I would rather, in the moonshot, say, liberate those claims to me right now, okay? So I can see what people, not what they're doing, what they're not doing, okay, that would benefit them because they're not engaged in their care. We're going to say that, mammogram ordered. High-risk individual, doesn't get the mammogram. Now they're stage 3. Now we're doing axillary dissection, radical mastectomy, all sorts of treatment as opposed to lumpectomy and pill. If we had gotten it and it was 14 millimeters. So we have we use these in our our commercial contracts. We don't use them enough in government pay. And frankly, government pay is everything. That's where we really need the benefit of these claims.
That really fascinating kind of thinking about this. And I want to come back to the data piece of this in a minute. But, you mentioned the healthcare inequities, and also in doing that, also you mentioned driving outcomes and creating more profitable pieces, which quite honestly, those tend to, I think in our business sometimes are not viewed together. They're viewed separately and contrary to one another. So it's really interesting to me because look, we're coming out of a pandemic and COVID shined a very, very bright light on the healthcare inequities that existed even pre-COVID, that exist to this day. And you mentioned kind of a lot of those patients have the certain profile. They might be Medicaid. They might be traditionally viewed as the least profitable, but you're actually looking at it in similar things to shine a bright light on both. How do you use kind of one to hopefully eradicate the other of the healthcare inequities? Because that's obviously paramount to your strategy. It's paramount to the mission of your institution. But can those coexist together? And how do you look to use one to eradicate the other?
Yeah, sure. When we were trying to solve a business problem, how are we going to get paid in the future? And we stumbled upon community benefit and the opportunity to give better care to people that are most vulnerable. And if we could identify them proactively, we could give them disproportionate care in a more timely fashion, reduce expense, reduce the unnecessary utilization of services for disease states that really we should have clipped off earlier in that process. So frankly, the whole system is actually tilted towards vulnerable people. Again, that, by the way, they're people that tend to have disparities in care, okay? Communities of color, people that are low poverty status, people that have social determinants of health against them, and as an ER doc, I'm embarrassed to tell you this as well, I consider the downtrodden, use that old term, those that are vulnerable, as my patients. In Philadelphia, we were the family practice for a lot of people that are really challenged like that. And I was very proud of what I did. And I was the advocate to keep people in the waiting room overnight when it was cold and give a turkey sandwich and on your way, Joe. And by the way, rinse, repeat. He was back 20 more times that month. So, but I thought I did my job. What I realized is there's no system out there to systematically give the kind of resources consistently on a consistent basis that really allows for people to have the kind of access they need. Just because, and I would proudly say, hey, everybody has access to me, equal access. There is that difference. It's not equal, is not equitable. Because just because I'm available to you doesn't mean you have a car, someone that loves you, someone who can afford to put gas in it and drive you there, someone that'll be there to pick you up, or that you can actually come to the emergency department or a family doctor or a diabetic teaching or something like that. And you're you're an hourly wage person. You miss an hour. I'm 45 minutes. You missed an hour. You're fired. I mean, there's too much. People have too much at risk to get care. And those are obstacles that we need to fix. So along with this is you got to fix those obstacles. So frankly, the war for us in fee for value is not about commercial. I don't even think about commercial insurance for the most part. Don't get me wrong. I rely on my CFO to think about the commercial insurers, fight with them. And frankly, sadly, today, it's more adversarial than it's ever been in my career because of what this disruption with COVID and everything else. But I worry about the vulnerable people. And I've never felt better about that because the economic way out of this for us is value-based care. It is pay us for quality. And we will, if we're delivering quality, the costs will be lower for everybody. They will if we do a better job. But you need vision. You can't do this with visual flight rules. You need instruments. And those instruments are your analytics, claims, clinical information that show you who you're missing. So our patients that come in, whether you're on the managed Medicaid side or a Medicare Advantage or you're commercial, every patient has a risk score if you're in our system. So next to the name and medical record is a risk score. Okay. And some of them are highlighted because our population health care coordinators are surveilling that. You enter the emergency room at any of our 13 locations. We see that and we're on you. Okay. There's notification and pop-ups. People get treated differently on the floors if they're in a value-based contract or if they have a high risk score. We know transitions of care, forget it. We're not giving a prescription for this person to go see their family doctor in 7 days. It'll never happen. We're doing a transition to care call at their house or in a video or something to make sure they actually understand what we told them to do. And then they get callbacks to make sure, did you fill your prescription? Oh, you can't? We'll get it for you and we'll drop it off. So it really rejiggers the whole system. Good for everybody, but tilted towards those that are most vulnerable because the most vulnerable tend to have the highest risk scores.
Brian, thanks for describing that. I think I now have a much better view of what you're doing. So you're using the data analytics, you're risk scoring your patients that allows you to figure out who needs the interventions. Are you doing outreach to the community in the way that a population health approach would be, or are you talking about the patients that come to Lehigh Valley for care, either in the emergency room, inpatient, or outpatient setting?
There's an excellent question, David, and we had to have a strategy for that, and we have a strategy, and it's twofold, right? It should be just one system, but it was too much to do one. So we reorganized value-based care here. We had a chief insurance officer that we reorganized. We don't have anymore. The payment insurance all goes to the CFO, but the value-based care objectives are split between two docs. There's one that is focused on the acute care continuum. That's our chief quality patient safety officer, and that he has absolute control over the value-based contracts for every patient that comes in the hospitals. All right. And the 30 or 60 day continuum of bouncing in and out of SNFs, back and forth to the hospital to home, outpatient monitoring, virtual monitoring, and they're responsible for those people. And yet they have a team of people that follow those people, and I call them the acute side. On the non-acute side is a vast, vast system of proactive, lots of pro-risk stratification, lists that are created that go to care coordinators that are working lists. We have rising risk in this patient cohort over here. What's their problem? Get a grant. We've given tens of millions of dollars of free medications using grants by proactively asking, why did you not fill your prescription? I can't afford it. We'll get it for you. So we've separated acute and ambulatory. The two of them work hand in glove because there is overlap, but we're trying to tilt that even more. So the first part was inpatient. When you come in, that's where a lot of costs can occur. We got to fix that right away. We got to give them the best, most accurate treatment, make sure they stay involved with their care so they get the best outcome at the lowest cost and don't rebound back in and get readmitted. On the other side, that's where we're trying to reach out into the community. By the way, really hard, and part of this is the humility to know that hospitals are not the solution alone. You have to do this with a vast number of community organizations, from food banks to resident living, to temporary living, to street medicine, to the list is endless. And we decided, and you referenced the pooled trust, we're kind of proud of this. we realized we can't do this on our own. We can be a convener. We're the number one employer. We can get people to show up. But the reality is we need to work together in engaging, the schools districts, which are miserably in my market. Also all of the synagogues and all the churches and all of the bodegas and all of the grocery stores and all of those areas, and try and pull those people and say, what do you need? So to do that, though, takes a lot of money. So we had the pool trust, 50-year trust. It had about $80 million left in it in 2021, right in the middle of COVID. We went to our board, who believes in this lose less strategy and proactive care for those that are high clinical risk, who will be high financial risk, and said, listen, I think that we need to forever, because in 2025, we'd get a dump truck of $80 million. Well, that'll help with a lot of operating sins. It would be wonderful to get that. I said, don't trust us. Don't trust us. Don't trust the next leaders who might be here if I'm not here. We're always going to have social problems that we're going to have to bring these leaders from all these community organizations together. So we put that into a brand new subsidiary that is permanently restricted, okay, for community benefit and supporting the kinds of things you and we've talked about here in the last 10 minutes or so. And I can't even tell you the benefit of that. It's going to afford us to do things. We're very hopeful. We'll kick off an agreement with Blue Zones in the near future. It'll kick off tons of programming in the schools, okay? Because we have a children's hospital and we have a very sick pediatric Medicaid population. We can do a much better job. Women's care, women's health issues in vulnerable communities. We know what we have to do, but we actually have a pool of dollars that can drive the agenda and those. Now we have the data. It's a matter of how do we put them in place, operationalize, execute on those so they never stop. So you can't do it our own. I think we're really well equipped as hospitals to do it in the inpatient. Outpatient, we do a pretty good job, but we need community partners. And I think we've tried to supplement that with real deal dollars.
Dr. Hester, fascinating stuff, and I love the use of data and the thinking of how data can be more integrated. Obviously, there's privacy issues, there's data integrity issues, there's necessary, HIPAA is out there, it's real and it's in place for a reason. But you also talked about partnering with community and partnering with, community partners and other institutions. How do you balance those two? How do you use the data effectively to kind of achieve your mission, but also kind of protect yourself and the patients kind of along the way?
Yeah. So we have it's quite a journey. So go back to the data set, right? So when we had an opportunity when we decided we're going to do a prospective risk stratification play, okay, well, what data set are you going to use? We had a choice. It was either Humedica. You may or may not remember that one, which was used office-based scheduling and CPT codes to come together and risk stratify a patient practice, okay, cohort. Or there was Optum. Optum used claims data to do the same kind of thing. I was chief strategy officer at the time and decided let's do claims, even though we had none, except for our own, beneficiaries, because that was going to be the future. And we knew that the payers would never give it to us. So we were willing to have a fight. So we picked Optum, and then ironically, within a year, they bought Humedica. So we wound up having the best breed. And then we went to war. We said no data, no deal. It was 2 years of pain before we got our very first data use agreement. We now have 18 data use agreements with our top commercial carriers. We get monthly downloads and claims. Okay. Now, monthly downloads and claims, built pipes to connect it to highly optimized Epic. So for every patient we either have claims and clinical information or we have clinical information. Okay. And sometimes we'll use Healthy World, risk profile out of Epic. But most times we're using the Healthy World risk profile with a modulated Optum, if you will, risk factor to be able to deliver. Now, the reality is that gets into the weeds, and I don't think you really need all that. I think you can have claims or clinical, even just clinical, and you can do a really good job. The enemy of good is great here. I mean, frankly, if you just manage diabetes in your community, you'd probably save a lot of money. Okay. But, I think you can do a really good job with population health. The question is, now we're sharing data, and where is it at risk? Look, we had a very public, very big cybersecurity incident with Black Hat a Russian group within the past year, and we refused to pay, and fortunately we were able to kind of repel them from the main corpus. But all the hospitals are going through that kind of stuff right now. So you got to worry about it, but I don't worry about it. I think we do the best we can. We have data use agreements with payers who are very controlling of their data. They're confident in giving us data. Epic, we share hundreds of thousands of files a month, okay, with hundreds of healthcare organizations across the country. I don't worry about that stuff. Probably maybe it's ignorance, but I think there's a way to protect it. We do a pretty darn good job. And as far as the moonshot, I wish CMS would take the leadership role in having that brilliant repository, robust repository of claims data for Medicare and Medicaid, and release the dogs. Make it available to responsible organizations. Make us go through 10 steps of HIMSS, whatever, to show that we can actually be responsible. And we will use that data to provide better care, reduce disparities that are on adjacent zip codes, reduce the cost of care, and have better outcomes. I am highly confident that we have great organizations that do that. In our own state, there's UPMC who does this fairly well in their Medicaid and Medicare, but so does Geisinger. The provider payers, I think, have a leg up here. They're responsible. They have a mission, and I think they could do it. And we'd love to glob onto their success and be part of the solution. But, we can't keep going like this. My worry is that we just allow it to crash. A lot of vulnerable people will get hurt. And then where are we? But for me and our organization, we're not going to crash, but we want a softer landing. And unfortunately, COVID took 5 years of a 10-year runway away. So now we're struggling like a lot of other people, but I still don't, I'm undeterred. Population health is the only way to do this. Lots of industries fail because they can't keep up with innovation or other things. The successful ones deliver a higher quality product at a lower cost, and they win. So I think that's the only way for us.
Well, Brian, thank you so much. And I know we're coming towards the end of our time, but I have to say you've really blown me away. I mean, I just so impressed with the vision and the implementation and the restructuring and you're in this with both feet. This isn't, let's put a finger in and let's see if this thing's going to work. So would you say, in terms of giving advice to your colleagues that are out there who are going to be listening to this podcast and listening to you, would you say, look, we're at Lehigh Valley, we're on this grand experiment, and maybe it's going to work and maybe it's not. So sit back and watch us. Or would you say, look, the evidence is so clear, there is no other path? And if so, what advice would you give your colleagues who are leading health systems in terms of going down this road?
Okay, it's a tough one. Qualified for the moment we live in. But, I think what I've learned, though, is this is so much harder than I ever thought it would be. Just when you peel one layer of the onion back and you think you're there, there's 5 different dark spots you got to fix. And so I think, from 2014 to 2019, our first 5 years of population health, we were exhausted because it took us that long to get data use agreements in place, to build the pipes, to even have the representation of the material there. I look back sometimes and there are competitors in our market who said, we haven't seen fee for value work. We're not going to do it. We're going to do fee for service. As I look back at it 10 years later, heck, I think they were right. At least they could have made a lot more money if you were dedicated. We were dedicated to building a better platform to reduce expense, which I still believe will advantage us. Because 10 years later, we are as competitive or cheaper than our competitors. You have to get your company there before you can really win at this game. And then we have high quality and good quality. We could always do better, but now we have a price advantage. Okay. Can you use that in your contracts? Well, we were about to, and then this little thing called COVID came. And we had 9% inflation last year, and we had to break every one of our contracts and go back and ask to increase our costs. Now, we were very tepid to make sure we didn't increase them in a manner that would harm our framework for value-based care. So we intend to get right back at those competitive triggers you can do when you have a value-based enterprise. Like, we don't give a crap. At some point, we're not going to care about site-neutral payments. I can't be worried about that. I have to move towards site neutral payments because it's the right thing to give people access and it's lower cost care. And if that allows people to get the services done early enough to do better and have better outcomes, we're going to do it. But you have to build that into the cost structure of the company. We were there, and now, unfortunately, with great resignation, 9% inflation, all the above, we've lost some years, but we'll be right back at it within the next year to 2 years. And what we've done in the short term, we've pivoted. We have value-based contracts. We've gotten out of risk because there's no stable platform for price. So we've moved all that money and more into quality incentives, and we're taking big bets on quality. And we've at least have good enough relationships to be able to do that during this fungible period. But we're both committed to come back to risk because I think we really want to take that risk on. So, I guess I'd say this is harder than you could ever imagine. This is a very tough time for me to tell you to jump in with both feet. We've been in it with both feet for a decade, and that's what allows us to play in the game. I wouldn't enter it right now. Right. I would take care of business, take care of home, get on terra firma, and then try and work with other organizations that are a little ahead of you and try and bring you along. But it's too risky right now for others to go in. So if the default is just watch what we're doing and see if the grand experiment works, like you put it, that's pretty good advice right now. But I'd love to see others. There are great organizations out there that are farther ahead than we are, that are doing great stuff in this space and are not getting down by this. There's a lot of talk about we're losing momentum in fee for value. It can't. The leaders that are in this both feet have to persist. We have to keep moving in that direction.
Dr. Nestor, thank you very much. Thanks for your insight. I love your enthusiasm. If you feel deterred after 10 years, it does not come across at all. And your passion for your moonshot and your passion for what's next and how to kind of navigate what's a very, very complex issue. I was talking to somebody today earlier about data, and somebody, I think the quote was, "How come it hasn't worked in healthcare?" And I think what you're saying is it may not have worked yet, but it will, right? And that's a tough thing to persist through. But I think the vision and the passion that you have is going to get us there, and will get us there faster. And I really do appreciate you taking the time to guide us along and share your time with us.
Thank you for the invitation. We'll keep up the fight and hopefully do things the right way. But thank you.
Thank you again, Dr. Nestor.
Thanks so much, Brian.
Alvarez and Marsal. Leadership, action, results.
First of all, I feel both a lot smarter and I feel a little overwhelmed, because I think that, from my perspective, is such an incredible balance of what you have to do every single day: deliver care about patient outcomes, care about your community, care about the cost. And I love how he said, the strategy to lose less. I think that was a very creative way of saying you've got to have a financial guidepost, and you have to look at the financials. But also, we're talking about how you use data to drive what will be a new care delivery model, a new essentially model that we're in that next phase here. That his passion is both inspiring, but he's put a lot of work into this up till now, and to be committed to it through all this, I think is fantastic and pretty awe-inspiring, actually.
Yeah, I have to say, he actually surprised me. I've known him for a while, but I've never seen this level of commitment from him. And it really reinforces to me that if you're going to get something big done, you can't do it half-heartedly. And there's no doubt. You spend 5 minutes with him, and that's where this organization's going to be, and they are on this journey, and nothing's going to deter him from that. And listen, how can you argue with what he's trying to do? This is what our health systems, especially, or not-for-profits, were intended to do, which is to care for their communities. And that's really what he's talking about. And he thinks he has a way of making that work for them financially, which I think is really an important perspective that he has. You can't run away from your government payer responsibilities. There's nowhere to run anymore.
Right.
You look at the demographics of the country, the aging of the country, it's only going to be more of this, not less of this. And, I doubt we're going to see large fee schedule increases from Medicare or Medicaid, given the budget issues that we have. So, I think he's on to something, but I also thought his caution at the end, which is be careful what you wish for, is also, people are going to listen to that as well.
Well, it brings up a lot of things, and a lot of things that we've been thinking about. I know in our conversations with you at A&M, we've been thinking about is we're at that real kind of interesting point. We're at that fulcrum between we have these necessary institutions, we have the care delivery model. Data is prevalent. I think we're starting to, the data jump ball, if you will, is starting to get controlled a little bit more. It's starting to get shared. I was actually very impressed that, he pointed to numerous institutions now sharing data out there. And how do you use data as kind of this, this fiduciary to drive care? And it's not an asset. And then a lot of times in the old days, your data was your asset. But how do you release that asset to kind of change care delivery? We're in that interesting transition period of how you get there. But that's kind of it, right? How do you use all of this power, and how do you, whether you call it AI, whether you call it analytics, or how you use that and make it accessible to drive the best outcome? That's the name of the game. It's not easy, and I think you saw it directly in. We've had some steps forward, 3 steps forward, 2 steps back, but we're making progress toward that. That's pretty impressive from a health system to be, in one of the people driving that.
Yeah. And I think it's such an excellent point. I do think it's one of the reasons why sometimes CEOs do need to have some outside counsel like A&M, frankly, to help them think through their strategy, because he talked about some things that I don't hear many CEOs talking about. He talked about 18 data sharing agreements with his payers. I hear CEOs talking a lot about rates and structures, but I don't hear them talking about data sharing agreements that often. The other thing that I think that he did, which we heard in one of our last What's Your Moonshot podcasts from Rob Allen, the CEO of Intermountain, these two organizations have actually structured themselves differently. They've created an organization that focuses on this value-based care out in their community, separate from their sort of operational aspects of their medical centers and their medical groups. And, again, that's a bold move, but I believe that if you're really going to chase these goals of value-based care, you probably do need some of these organizational structural changes.
Yeah, that's well put. And rightly or wrongly, sometimes you don't think of large health systems as innovators, but they've managed to be the large community health system, caring for patients, caring for, indigent care, caring for the bridging the inequities of care, but also innovating. That's impressive and hard to do. And my hat's off to him, and also to the previous guests we've had here, that you see that happening, which is actually pretty cool and pretty inspiring too.